Welcome back. Hopefully you're able to take a little break between sessions here. I know the topic of asepsis seems rather long, but in the second portion of this discussion, we'd like to focus a little more on the actual preparation of the surgeon and patient for surgery and establishment of the surgical field. So let's start off by talking about the actual surgical scrub. The goal of our surgical scrub is to reduce the number of microorganisms on the skin and suppress this level or the number of microorganisms for the duration of the surgical procedure. So hopefully we're only going to be looking at most a couple of hours. But we need to consider that there are more than one type of microorganism that may be present on our skin. As we move about our environment, especially in something like a veterinary hospital or even an area where there's treatment rooms and animals or barns and stalls, we know that it's possible that we're going to pick up contaminants from that environment. And these contaminants don't normally live with us. Therefore, these are referred to as transient microorganisms that kind of jump on us in our daily activities. This is why it is very important on surgery days that you maintain yourself covered with a white coat or a surgery gown. So we try to minimize the number of transient microorganisms from our environment. These microorganisms are actually easier to get rid of because they don't normally live with us. So as we're going to apply the surgical scrub, we may be able to physically remove them with the actual process of hand washing or mechanical scrubbing. The other type of microorganism that we have are those that live with us on our day-to-day basis. The resident microorganisms that are harbored in the more superficial layers of our skin, not part of our makeup. These microorganisms, we hope to, with the application of antiseptics, that we can suppress their growth in numbers, but we will probably not be able to completely make ourselves microbial free as you would with sterilization. So as we remember, we can't make ourselves sterile, so we're going to apply antiseptics so that we can suppress or eliminate bacterial growth and development. The most common antiseptics that you're going to see in our hospital and probably most veterinary practices at this time are chlorhexidine gluconate at 4%, povidone iodine, which we all call betadine, at 1%, and then you'll see some admixtures of something like chlorhexidine and alcohol. Alcohol at 61%, as we've been talking during the pandemic, all the hand sanitizer really to be vital has to have at least 60% alcohol. And now they've shown that you don't want methanol, that you want to make sure it's alcohol. So alcohol itself is a very good antiseptic agent. Most commonly when we're performing surgical scrubs, we have a designated area. You can see in our hospital, there's usually stainless steel sinks. You notice that we have the gooseneck faucets. Those are to help facilitate us being able to wash and move our hands without touching things. And then we usually scrub with purchased sterile scrub packets. As you can see on the right, they typically will come with a small combination brush sponge setup and a nail pick. These can be purchased with any form of antiseptic. We usually have just the chlorhexidine and the betadine scrub brushes. Whenever you pick up a little packet of that scrub material, you want to make sure before you even open it, because it has been sterilized, that you give it a good massage, because if they've been sitting around it all for a while, the antiseptic solution sometimes leaches out and is sitting in the bottom of the package. So if you open it up and just take out the brush and the sponge, quite often the antiseptic is still sitting in the package and you don't have quite as much to work with when you get ready to scrub. Okay, again, what are our objectives? We want to apply mechanical, physical activity to help remove the gross debris, dirt, and oil. And again, just touching veterinary patients, you're going to get hair, dander, oil. I might walk by and open a dog's mouth to do an oral exam for somebody, I might have oral contaminants. Again, hopefully these are all transient organisms that the physical action of mechanically scrubbing, washing my hands is going to help remove it. So our goal with this scrubbing is to reduce transient organisms to near zero. Just get rid of all of them. But the application of the antiseptic for a period of time is hopefully going to have a chemical action on the resident organisms that live with us so that we can suppress them during surgery. A very, very important concept is the term contact time. Okay. Contact time is to reduce microorganisms by a time-dependent exposure to antiseptic. So contact time starts after you've wet your skin, when you've completely applied an antiseptic to all areas of your skin that you're going to scrub, so usually from your fingertips to your elbow. Contact time starts when you've covered it with antiseptic, and then you go 5 minutes. So we want to make sure that we have a time-dependent exposure at 5 minutes. So why are we worried? We need to think about how our antiseptics work. For those that like the iodine or betadine products, we know that the mechanism of action for this is based on iodine, which is in a carrier, which is polyvinyl pyrrolidone. And it's that's similar to just straight iodine, it's just less irritating. Iodine or betadine gives a very broad spectrum effect across the range of bacteria, and it works by penetrating cell walls, moving iodine in, and oxidation. We certainly don't demarcate that orthopedics likes iodine and soft tissue likes chlorhexidine, but I will say we do see more iodine or betadine usage on the orthopedic side. Some of it is just surgeons' preference, what they feel works well for them, what they like, and sometimes if you're scrubbing, it's what seems to be less irritating to you. Now, chlorhexidine gluconate at 4% is a cationic bistiguanide. It seems to be a little more effective for gram-positive than gram-negative, fairer as a fungicide. And the thing that I like about it is that it's active for up to 6 hours, has a fairly quick onset of effect, and then the exposure to, a time-dependent exposure to chlorhexidine may give you up to 6 hours of effect. Hopefully my surgery doesn't last 6 hours, but that way, if it's still on the skin of the patient, it's suppressing the bacteria around the incision. As you note, the mechanism of action, again, is disruption of cell membranes and precipitation of cell contents. Now, as we move into this new age, we're seeing far more antiseptic hand rubs. These are also being used everywhere as antiseptics in public environments. The idea behind the antiseptic hand rub was to give a topical antiseptic that can be applied to the skin, and you don't need water, and you're usually not going to have that physical action of scrubbing. Now, we said that physical action of scrubbing, which we know they talk about washing your hands and singing happy birthday, is good for removal of mechanical things. The idea behind antiseptic hand rubs is that we should still be able to apply them after just at least a quick washing of hands without scrubbing, and then the application of the antiseptic, again, is going to be time dependent. It is supplied in a number of ways. It can be supplied with something like chlorhexidine. One of the more common products is Avogard. You'll see it as a surgical hand rub in a container that's usually mounted on the wall and run by a foot pedal. But if I go see my physician, it's usually sitting on the counter as the same product for me to just wipe my hands off as I go through their office. As you know, this is 1% chlorhexidine and 61% ethyl alcohol. Rapidly kills, has a broad spectrum, and honestly, I think it works pretty good. Some people like Avogard because the lotion it is carried in is not as drying, but I will say when you put it on your hands and rub it in, it's very tacky. So you have to keep rubbing, and you have to wait till some of that tackiness is gone before you try to gown and glove. Now, you notice in the picture here where they're advertising Avogard, they have somebody scrubbing with no mask on, so we want to avoid that as well. The other product that we have in our hospital, and I would say a lot of the surgeons and residents use and like, is Sterilium. Okay, and you can see the listings. It's a little bit different. It's not in that tacky lotion that we see with Avogard. It comes out of the dispenser, far more liquid. I kind of feel like it contains more alcohol, but when I look at the makeup of it, it doesn't really suggest that. It's easier to rub in and you don't get that tacky sensation. But you see it has a very wide range of kill for bacteria, spores, viruses, etc. In our hospital upstairs, most of the surgeons do a physical mechanical scrub for their first procedure of the day. That way they are assured that their cuticles, their nails are all cleaned and they're all scrubbed. But because we do multiple surgeries, many times the second procedure, they may go with washing their hands, drying them, and application of hand rub. I don't suggest that probably just application of hand rub without physically cleaning your nails and cuticles is probably still a perfect idea. So I think as you go forward that you may find that more of these hand rubs appear. They are seemingly very convenient, but you want to make sure you think that you're actually getting your hands clean. A couple of studies have already been done looking at the use of hand rubs, and you can see in veterinary lab environments. But a survey was done with ACVS and ECVS, those are the European College of Veterinary Surgery diplomats, on what they use. And you can see 80% of surgeons were still using physical hand washing and scrubbing with chlorhexidine gluconate. All right, as we get ready to scrub, a few important rules. Everyone has to remove all jewelry below the elbow. We can't have any wrist or hand jewelry. Unfortunately, no rings in surgery. And as we talked with the gloves, we know that, the issue of having perforations at the site of rings is very high. So as a standard procedure in our hospital, we don't allow it. You really should clean and trim your fingernails. And I always hate to be the bearer of bad news, but we just can't have acrylic nails and nail polish, because even though you're going to put sterile gloves over your hands, if it flakes or you have bacteria underneath the acrylic, it's a sense of contamination. So for quality control, we have never allowed that. In the lab down here, nobody's going to say anything until we get to the live surgery. But I usually make the techs tell you because I always feel bad. And if you look at my hands, you'll see that I've never had nice nails. Okay, again, we're going to be scrubbing in stainless steel sinks with gooseneck faucets. And the purpose of that is you notice that the surgeon scrubbing here, you have to assume that awkward position of where you're bent or hunched over at the waist. So you're leaning forward and you want to bring your arms in with your elbow at a right angle, fingertips up toward the ceiling. And the purpose of that is as the water runs and you're going to focus your scrubbing between your fingertips and your elbows, water and soap is going to run straight off the bottom of your elbow. If you're standing up straight, the water is going to run and hit the front of your scrubs and you're going to look like you're soaking wet. And if you don't keep your elbow bent, the water is going to run down your upper arm to your armpit and you're also going to look and feel wet. So it's hard to assume that posture, but once you start scrubbing, gowning, and gloving, we know that that bent forward posture, one, helps you from being wet, helps you from having your hand towel while you're drying touch the front of your scrubs. And, as you see, even when you're gowning and gloving, you're going to be very cognizant of the front of you. So you need to kind of learn this terrible posture early. Okay, as you can see the person scrubbing here, they've actually wet their hands and you've noticed that the antiseptic's already been applied and now they're going to clean their nails. So either one, you can wet your hands and pick up the nail pick and do that and then apply the antiseptic. But whenever you completely cover fingertips to elbows of both hands with the antiseptic, you're going to look at the clock and you need to have it on there for 5 minutes. Everybody divides their 5 minutes of preparation time up individually, and you've got to find out what works best for you. I typically choose with my 5 minutes that I start off, and I always am going to work from my fingertips towards my elbows, because my fingertips is what is going to actually be in the surgical field. I don't generally do my surgery with my elbows in it. So you want to start with the area that you want the cleanest and work away. I go ahead and divide my time up so that I scrub for 2 minutes on my right hand and arm, then 2 minutes on my left hand and arm, and then I turn and go back and do about 30 seconds on my right, and then about 30 seconds on my left, so I get out to 5 minutes. Okay, my preference is I usually start the scrubbing of my fingers and my cuticles with the brush side of the sponge because I'm mostly worried that's the place, the little nooks and crannies around your cuticles and in between your fingers where the bacteria are going to want to harbor. So I usually start off and do that with my hand. And after I've done that for, if the first portion of my time, I may flip my brush over and then do further down my arms and hands with the sponge side. You've got to figure out how, again, that works best for you. But very important that you scrub, scrub, scrub well around your cuticles and in between each finger all the way down. As you keep scrubbing, you want to make sure that you keep rotating your hand. So you've got to scrub all surfaces of your hand and your arms. Keep your fingertips towards the ceiling. And as you rotate, you're going to do the top side of your palm, bottom side, round the base of your wrist, and keep rotating around your wrist and arm. Again, fingertips up, elbows bent. That way, if there is excessive water or soap, it will go into the sink and not down your armpit. You notice in this picture, there's a lot of soap, probably more than you'd normally have. You also notice that the soap lather is gone beyond the elbow. You want to try to avoid that, and that's also another reason why you can't wear shirts underneath your scrubs. Because if you get any soap or water above your elbow and you have a shirt there, it's going to wick that water up. Then even though you're putting on a sterile gown, that water and that wet cloth below your gown is a source of contamination. So you want to be very careful, scrub fingertips to the elbow and try not to get too far above there. Again, making sure you get all aspects and all sides of your fingers and on both arms, both hands. Okay, looks like going down the second arm here, fingertips up still, probably bent forward. Okay, after you get your 5 minutes and you feel like, okay, I've scrubbed, I've lathered, you're gonna rinse. Again, make sure your posture is bent forward, your elbows are bent at right angles, fingertips up. It's usually easiest to pass one hand at a time underneath the running water of that gooseneck faucet. If you keep it so that your fingertips are pointing up and you just gently rock and curve your hand back and forth, you want to make sure that all soap lather is rinsed off your fingers, hands, and arms before you're done with your scrubbing. So I usually do my right arm first and get all the soap off all the way to my elbow. I'll pull that hand back and then do my left one. If I should inadvertently touch the sink or neck of that faucet during any time during the scrubbing, it's a do-over. You got to start over. So you need to be honest with yourself because your patient's at risk here. So if you recognize a contamination, please stop and try to do it over. Okay, once you're done rinsing, you're going to have a lot of water. Usually give a little shake, fingers up, keeping the elbows. Now, she's standing up a little straighter because she's pushing to go back through a door. But again, you want to stay a little bit bent over so that water doesn't run off your elbows. Okay. Once you go into the OR, we have the surgery gowns opened in the OR. We don't open them in our scrub rooms. So they're in the OR, and the surgery gown and hand drying towel are all together. We will also ask that when you are doing surgery prior to going to scrub, that you open your surgical gloves and add them to the towel and gown pack that will be there. And we're going to go through that. Okay, and then we'll have assistants and nurses available to help you. It's impossible to gown yourself because somebody has to tie you in. So this is a video that I have up on Canvas as a separate, and hopefully this isn't like World's Funniest Home Veterinary Videos, but we did this in the lab to try to help you with a demo for gowning and gloving. Now, we all recognize that nothing takes the place of actually doing this yourself.
So here we have a sterile surgery gown, and you'll notice that the surgery gown is in an outer packaging. These packages are sterilized by radiation. So at this point, the whole inner package is completely sterile. Linda's now going to go ahead and show you how to open this sterile package. So it peels apart at the top. Now, once we peel the outer packaging, we're going to expose the surgery gown, which is wrapped inside a light drape. Now, once you see this package is open and Linda has her hand on it. Is that inner package sterile or contaminated? Okay, so once Linda's non-sterile hand touches that package, it's now contaminated on the outside, but you'll notice as she puts it on the table that she can unwrap it and maintain the inside of it in a sterile manner. So with the four-corner wrapping, she gently folds each one away so that she never crosses her hand over the center. And the packaging for the drape actually creates a really nice, I would call a sterile island for you. So you notice Linda's hand never touches the inside of that packaging, and we now have our sterile gown and a sterile hand towel. You will notice that all surgery gowns are pre-packaged in the same way. They're all folded identically, and you see that the hand towel is on top. There's a dark blue binding, that's the neckline for the gown. And then we have some printed information about the gown, generally indicating the size. When you see that printed information, that's important because that signifies that's the inside of the gown that will go towards the surgeon once you're prepared to gown and glove. Now, for us to gown and glove, we're also going to need to have sterile gloves placed in this sterile field. So we're going to do the same thing with our gloves because we have so many students in the lab. We ask that all sterile gloves be placed on top of the open gown. And sterile gloves are pre-packaged in an outer covering, which is not sterile. Linda's peeling it away. She's never going to touch the inside, and she's gently going to flip them on to the sterile island. So now we have sterile gloves and the sterile pack on top of this sterile gown. So one question you need to ask yourself, what happens if Linda flipped those gloves and they actually were part on the sterile island and part off the sterile island? What would you do then? Okay, when we've scrubbed our hands and we're ready to gown and glove, we're going to approach the sterile island. And the first thing we're going to do is make sure that we don't have any water dripping from our arms. And we're going to gently reach in and grab the folded corner of the towel, lift it off without touching anything else, and move away from the table. The towel can then be used to dry the hands. Make sure you stay bent at the waist, elbows bent, fingers up, and start by drying the fingertips to the elbow of one of your hands, doesn't matter which one, and make sure you get it completely dry. It becomes very challenging to gown and glove if you are damp or have any soap on you. Make sure that you stay bent forward so that you don't inadvertently stand up and have the towel hit the front of your scrubs. So as you're bent forward, the towel hangs straight down. Okay. When you feel like you're completely dry, you're going to use the hand you just dried, reach underneath and grab the dry end of the towel, flip it around, and use that end of the towel to dry off your other hand. Do it the same way. Keep bent forward, fingertips up, elbow bent, rotate around your arm to get this dry. Okay, we're now ready to put the gown on. Again, stay slightly bent over, and you want to be very careful as you approach your sterile island. Remember, everything on the blue is sterile, everything outside is not sterile. When I pick up my gown, which is always folded in the same manner, again, I see the handwriting on the gown, and I see the binding that goes along the neckline. I'm going to reach under, and I'm going to slide my fingertips so that they're just below the binding, over top of the writing, and the gown is folded in half here. As I pick up the gown, it's important to step back from the table, because if you allow the gown to unfold in front of you, it'll hit the table and become contaminated. There's a fold here, right along the side. I'm going to slide my fingers forward to the fold, and that is where the sleeves and armholes are going to be. So I can gently let the gown unfold in front of me, and I can slide my arms into the sleeves without having my fingertips exposed for closed gowning. Okay. Magically, an assistant will appear. It's amazing, they always appear, and they'll gently, without contaminating your gown, go ahead and fasten and tie you in the rear. Now, we use wraparound gowns to cover our back. You do not want to try to wrap your gown around with your hands inside your sleeves, because it's very hard to tie the strings. The glove, once we have our package open, we're going to go ahead and pick up our glove. You notice that the gloves come and they're completely cuffed. The size is on the cuff. You can either close glove with the cuffs left in place. I like to have mine uncuffed. And the reason for that is I'm going to lay the glove on my forearm, with the fingertips pointing towards my elbow and the thumb of the glove laying over top of my left thumb. I'm then going to use my non-dominant hand inside my glove, inside my sleeve, to open the cuff, and I'm going to start feeding the cuff of my gown into the glove, and I'm going to slide it and flip it right over the top. Once I've done this, the thumbs should be aligned so that I can gently grab the gown and the glove. Okay, don't just try to pull your gown because you'll rip it. Grab them both, and you can slide them forward and then manipulate the cuff of your glove over top of your gown. So ultimately, what you would really like to see, fingertips in the right holes. You want the cuff, the cloth cuff of the gown over top of your knuckles, and you want the glove well up over top of the sterile portion of the sleeve. Okay, we don't want to have any of the cloth cuff exposed. Sometimes, your fingertips may be long and you can remanipulate them later. Get your other glove on first. Okay, so again, this is the way I like to do it, and if you want to leave them cuffed, that's fine. Fingertips to elbow, thumb to thumb. I'm going to lift open the cuff of the glove, feed the cuff of the gown in, flip it over the top. You can see, here's my thumb, there's my thumb. I'm going to grab the cuff of my glove and my gown and just gently pull together and organize them in place. Once I have both my gloves on, I can fix them so that they're comfortable, make sure my gown's not bunched up. The sleeves are typically very long. So you notice the cuff is down further on one hand than other. That's okay. It can be anywhere from, the ends of your knuckles up, but you want to make sure that the cloth portion of the gown is completely covered by the sterile latex gloves. Okay, last thing we need to do is finish gowning by passing our tag. So you'll notice we have a tag that's bifurcated in half, purple on this one, sometimes they're green, doesn't really matter what the color is. On the right side, The string is very long because it's going to take the gown all the way around my back so that my back is kept sterile during surgery. So what I want to do is I'm only going to maintain sterility by touching the white portion of my tag, and I'm going to detach it from my gown. So I'm going to pull the left string off. So your tag always stays on the right string. Now, this tag is clean, contaminated, sterile. This is sterile. No one's touched it. So I could pass this tag to one of my surgery mates that's scrubbed in because they're gowned and gloved and they're sterile. Fortunately, that it's not always convenient. So what we do is we can pass this to somebody who's not sterile as an assistant, but they can only touch it to the purple portion of the tag. So Linda has a hold of it, and she's not going to pull on it. I'm going to gently pirouette around, and you see that the gown comes around, covers my back, and as I turn, she holds the tag tight, and I just pull the string off. So I now have a completely sterile back, and I can tie myself in. So when complete, here we are. So how do you remember? Everybody stands and they looks at the tag, which one do I pull off? Most people are right-handed, so remember, it's going to pass to the right. Is one way. You can also tell that the string that comes across your front from the right is longer, so that's the one that has to go around the back. We never want to reach ourselves around the back because this hand is sterile. Our surgical field is now shoulders to waist. Right? So our hands need to, now that we're gowned and gloved and everything's sterile, need to stay within our surgical field of shoulders to waist. We want to avoid doing a lot of this or a lot of this, and we never want to reach the lower limb.
Okay, so that's certainly a video that you can review when we go into the asepsis lab. I'm happy to physically demonstrate it with you. I think it's always pretty fun to watch everybody gown and glove for the first time. And I always threaten that we'll video you and show it at white coat or graduation at some time so you can remember. It just takes practice. Once you get the understanding of how to do it, you don't even think about it. So now let's talk about the preparation of the surgical patient. Again, very much like the surgeon, we're dealing with living tissues and we're worried about infection from our patient. So we're going to be applying some of the same principles and antisepsis to these. We want to try to minimize how much dirt and debris our patients bring into surgery. Especially if you're working out in large animal, you sort of have a limited sense of what you can do as far as keeping that patient free of debris overnight. We also would like to just make a blanket statement. Wow, it'd be great to avoid operating patients that have diarrhea or some significant dermatitis. Unfortunately, those are sometimes the reasons I have to operate patients. So we would just like them to be as clean as possible. If the patient is very soiled or has soiled themselves overnight, sometimes we may quick clean them off or bathe them before surgery if needed. We try to also be cognizant of, if they have a load of ectoparasites, certain times of the years, we might see patients with a lot of fleas on them. The minute you anesthetize those patients, the fleas would be jumping everywhere, including into your surgical site. So we'll typically treat those patients with something like Capstar before surgery to try to avoid that situation. We used to be a little more aggressive about doing rough clips on surgery sites prior to surgery, and we now kind of avoid that. Having especially pyoderma in orthopedic patients that are going to get implants is a huge issue. There are times we actually anesthetize our patient, start to prep it for surgery, and once the hair is being clipped away and they see how much pyoderma there is, the surgery gets canceled. The problem with clipping them the day before is if you do any micro trauma or abrasion to the skin, you now have that window of time, 12 or 24 hours, for the bacteria to grow in an area that probably the medium is better. There's a little bit of blood and serum there. So we absolutely don't do that. When we're clipping patients for surgery, we typically will use clippers with a 40 surgical blade. And the higher the number on your surgical blade, the closer the clip is. So you can see it in this video here, people prepping the dog. They should be wearing an apron. You see that's a good job on the right. Somebody else came up to help and they don't have an apron on. You also notice that as they're clipping, they're vacuuming around this patient. You see on the side towards the camera, there's a huge pile of hair. We want to make sure that we check all the way around our patient so that when we've clipped, that hair does not go into the OR on that gurney with that patient. Some people suggest that maybe if you have dogs with longer hair or a lot of mats, you could use that number 10 blade, gives it a rough clip. It's not as close as a surgical blade. It may help in some situations if the patient's really matted, but most of our clipping is done with a 40 blade. Shaving with a razor, that can be done as a part of surgical preparation, but again, you need to be very careful because if you scrape or cause microtrauma to that skin, again, you're setting it up for bacterial overgrowth, and we want to be cautious about doing that. If we end up using a razor for a specific area, we want to make sure we soap that area up. We'll usually just use our scrubs with the soap in it, like a chlorhexidine, and then try to avoid damage to the skin. Okay, I think we talked on last time how important it is that that dirty prep, so the clipping, getting rid of the hair, and what we would call the first dirty scrub is all done outside of the operating room in a prep room area. Okay, after we've adequately clipped and cleaned up the hair, we're going to do the dirty scrub. And you notice this is not a sterile procedure. In the upper slide, you can see that they're using betadine. This was a case from just last week, a dog that has a big skin flap and a wound on its neck. And you notice the person scrubbing is wearing just purple exam gloves. So in the dirty scrub, our goal is to apply the antiseptic, and it's going to have contact time, but we're going to physically scrub the skin and the areas around the wound until we have all gross debris gone. So what we'll typically do is scrub, scrub, scrub. I turn the sponge over and I look at it, and if I'm still getting dirt and debris, then we keep scrubbing. So we don't use the contact time of 5 minutes to say that's always our endpoint, but we have to have that at least a minimum. Always remember too, that you want to make sure the cleanest place is closest to where your surgical incision is going to be. So in this situation, we've got a big skin flap here. She wants to go all the way around the room. Usually the actual wound bed area, we don't put a lot of soap scrub into those sites. We'll go ahead and we'll be rinsing them out and flushing them with saline. The bottom picture shows after Christy has done a nice job of scrubbing this wound. She re-clipped it all, and she has actually lavaged the whole skin site to get the betadine off with just some warm saline. In patients that don't have large gaping wounds, we often will use alcohol or Zephyrin to clean the soap-laden antiseptic, whether we're using chlorhexidine or betadine, off the skin. So saline, alcohol, chlorhexidine. We find some animals have more reaction to one product. Sometimes you'll be cleaning it up with betadine and alcohol, and you'll see the animal break out in hives. We usually administer Benadryl at that point and switch to a different scrub. Okay, our dirty scrub is done. We vacuumed. We've made sure that the transporting table is clean. We're about ready to move into the OR. Many times in the OR, our surgical packs are open. So again, we don't want to bring debris, no white coats, no aprons that we've been used for scrubbing, nothing like that goes into our OR. Okay, inside the OR, we're going to prep our surgical site one more time. Okay, so we refer to the second prep as the sterile prep. So once we get into the OR, we're going to use similar antiseptics, but they are antiseptics that have been kept in a more sterile manner, and we're going to apply them with sterile gloves. So again, depending on the procedure, we may be doing our sterile prep with chlorhexidine, with betadine, and then, as I said before, we can either rinse with alcohol, Zephyrin, or sterile water. Now, this is done with the surgery nurse open gloving. So we're going to go through that in lab, and this is one of the more common reasons that you do use open gloving, placement of catheters, especially in equine, doing sterile preps. So no gown, but she's going to put gloves on in a sterile manner. You can either purchase prep sets, as you see below, in sterilized containers, disposable containers, and on the left is a sterilized container of 4x4 sponges. On the right are what we call cherry pits. We can place the antiseptic scrub on the 4x4s, and then we can place the same antiseptic without soap, what we call a solution, on the cherry pits, so that we can actually scrub the site, make sure there's no more debris, we dry it, and then we can paint it with the cherry pits. It's a fairly inexpensive way to do your sterile prep. We used to actually make our own sterile prep sets, which can, we have to think about time, what it costs to sterilize those, technician time, and then we'll show you where we've gone today. But because sterile prep kits are still used in many practices, I just want to go through this. So you see Robin, our nurse here, she's open gloves, got sterile gloves on. She's going to reach into the container. She has poured a antiseptic with a scrub onto 4x4 sponges, and she's going to start scrubbing the surgical site. Her focus right now is to make sure that she does the first pass and the most clean scrub right over where she anticipates that incision is going to be. This dog is prepped for a spay. As she continues to scrub, she's going to work away from where the surgical incision is, and usually they may use a circular manner. Anytime her scrub sponge touches the adjoining hair, you're done. It gets thrown away. So we don't want any hair that's contaminated along the outside of the clipped area to be brought back with contaminants to where the incision is going to be. After she's done scrubbing, and typically the surgical sterile scrub will go another 5 minutes, she takes a 4x4 and folds it up so she doesn't have it sticking out beyond her fingers, and she's just going to dry enough to get the soap portion of the scrub off the skin. Again, she's going to start right down the middle where the incision is and work in circles or semicircles away from the incision on each side to get all the soap off. And then last but not least, in the other container that had the round balls called the cherry pits, we've poured a sterile solution with no soap. Okay, so it's just a solution, and she's going to paint it on the skin. The purpose is to place an antiseptic so that it stays on the skin and continues to impact the local bacteria of the skin with suppression. So here's on the upper slide painting a spay incision, and on the lower slide they're painting an orthopedic incision. So you're not scrubbing it anymore, you're just putting one light cover on it. Now, where we've moved to, and actually last year we moved to this in the operative practice lab, is we're purchasing the one-step skin prep kits. And these come with either chlorhexidine, betadine, you can buy whatever you want. They also come in different colors. But it looks like one of those soap wands you might scrub your dishes with. So when you purchase it, you can see that Christy has put, she's open glove, put sterile gloves on. She's going to grab the handle and then just punch the top end of the handle. And what that does is it causes a release of the antiseptic solution that's in the handle to flow down into the bottom sponge. So she holds it with the sponge pointing down, and she waits until the sponge fills with antiseptic, and then she's going to go ahead and she's going to basically paint the surgery site. So looking at the dog that had the big skin flap, she doesn't want to go right on the granulation bed, but you can see as she goes around, she kind of dabs it, but once she gets to the far outside, she's never going to go back in. So we're just trying to get a layer of antiseptic. With these one-step kits, we don't do any of the first scrubbing with the soap. This is a sealant within this antiseptic, so we just paint this on, and as I said, you will be using this in operative practice. They recommend that you allow it to dry on the skin, and then after surgery, we don't scrub it off the skin. So we explain to owners why their pet might be going home with orange or green antiseptic, but it has continued activity on suppressing bacterial growth after surgery. So I actually quite like these. Okay. Okay, so now it's time to create the surgical field, and we're going to do that by actually taking our patient that we've made the skin as good as we possibly can, and we're going to place sterile drapes around our surgical site. So we want to allow the draping of the patient to expose the surgical field, but it allows the surgeon and the assistant to move right up to the table so that there's continuity between the sterile surgical gown and the sterile surgical drapes. This also allows you to pull a sterile instrument tray up, but you notice in the slide on a picture on the right, we have Dr. Smeek observing the surgeons. He's not sterile, he just has scrubs on. So he has to stand a little bit back and kind of leaned over because he doesn't want to contaminate their field. So again, the purpose of surgical draping is to isolate a very small area associated with the surgical site that you're going to have, and then you want to cover the rest of the patient so you don't risk hair or dander going into your environment. You also don't want to risk the surgeon who's going to be covered in a sterile gown inadvertently hitting the leg. So I've added a picture of a large animal prep, and this is my husband getting ready to do some surgery on a foal. He's got the leg suspended, but you see that the rest of the horse and the table has got a sheet over it, again, to help the contamination in the room. But when he actually puts his drapes on, he doesn't want to risk running into one of the other legs of that horse if it's not covered as he's moving around doing his surgery. Now, we apply 2 layers of draping, and again, it's a physical barrier. We use all disposable drapes now. You certainly could use the cloth drapes as well, but we're trying to create water impervious barriers. So as you can see, sometimes in surgery, we might be lifting out some tissue that may not be normal and placing it on top of the drapes. We don't want to risk that the drapes get moist and wick any contamination up from that patient's skin or hair underneath the drapes into our surgical site. So again, everything is to try to keep our site sterile. So draping we're going to start with placing 4-corner drapes. As I just said, you can either use pre-purchased disposable drapes, which is what we have, or you can use cloth towels. You can wash them, fold them, and sterilize them. If you look at the amount of work it takes to do that, you may find cost effectiveness goes with buying pre-purchased drapes, and it certainly does for us. These 4-corner drapes are going to be placed around the proposed surgical site, and we're going to leave a very small amount of skin exposed next to where we're going to anticipate our surgical incision, and everything else gets covered. So we're going to be demonstrating at first an abdominal incision. So we're just going to leave about 2 centimeters of skin exposed on either side. Now, as we place these drapes, they're pre-folded, and you can see there'll be a fold up at the top. We always want to make sure that the fold is placed down towards the patient. So we don't want to see the folds up. That's a no. And we're going to show you how to position your fingers on the drapes to protect your sterile hands while you're placing these on. Again, in this particular situation, we need to make sure that the midline of the abdomen, the linea alba, is exposed. So you can see the drapes are placed up over top of the mammary chain on the side and just backed away enough to expose enough skin that the surgeon can see the midline. Once you've placed 4-corner drapes, You can move them a little bit away from your proposed surgery site, but once they're on the skin, you never want to slide them towards the surgery site. Now, part of the reason we want to make sure that all those mammary chains are covered is just like your fingertips and cuticles. You can imagine, even with clipping and scrubbing, that's going to be a place that harbors bacteria. Four-corner drapes are typically attached to the skin with towel clamps, backhouse towel clamps, and we put them in the corners where the drapes overlap. You just want to grab a little bit of each drape and a small amount of skin. We're really not trying to do body piercing with this. We now in our clinic have four-corner drapes that have a line of adhesive on it. Obviously, those are made for people. They're okay, but you couldn't just use them without towel clamps. So I think unfortunately for our veterinary patients, things don't stick to the skin of veterinary patients very well. Again, surgeons need to think, even if this is just a spay incision, I want to make sure that my four-corner drapes are placed in a position that if something went wrong in surgery and I should need to extend my incision for any reason, that I have enough room. Because once they're placed, if you need to extend your incision, you cannot cut through those drapes. So the four-corner drapes, they're pretty narrow here, but you can see they gave me more length on the incision in case I need to make the incision longer. That's up to the surgeon to make those decisions. Okay, so here I am with my patient, Sylvester, and in a little faster time, we're going to show you putting the drapes on. So I've taken the drape off the table. I'm rolling it around my hands, and you see the fold is down. I'm also very carefully trying to bend forward because I don't want the front of my surgery gown to touch the table. And I've placed a towel clamp into Sylvester. He definitely doesn't have drapes stick to him. Again, just unfold it, leave the fold at the top, and the fold should be away from the surgeon. I put the towel between my second and third finger and roll it backwards so that my hand is covered as I lay it down, and I'm going to go ahead and keep clamping. It doesn't really matter what order you put them on in. I find that usually if you put the one rostral and caudal first, they stay in place. Depending on the conformation of the dog, some will slide off the sides. You don't want to reach over a patient and drape. So you see I'm grabbing a towel clamp and I'm going to carefully walk around the table and go to the other side. My hands are covered. I step back. I place my drape, slide it away from the incision a little bit, and then I clamp it. So because I moved to the other side of the table, I brought my clamps with me. So I'm trying to minimize the number of times I'm walking around in there. See, when you're putting the towel clamps on, bring them in perpendicular. It's easier to grab the skin. So here we have our four-corner drapes all in place. Now again, different species, different kind of joint, orthopedics. Here we are, got a leg extended, and we need to cover that hoof. So the rubber glove has been placed after the hoof has been cleaned and scrubbed, but now we're rolling down a sterile cover and clamping it into place. So my husband's trying to expose the hock region here for arthroscopy. See in the middle picture, somebody's standing next to the horse pushing on the stifle to extend the leg, okay? So once he gets the cover on the lower limb so he can manipulate it during surgery, his version of four-corner draping is placing the drapes immediately around the hock as he is in the right picture. This horse is still gonna have another top drape put over it. So everywhere you drape on a patient might look a little bit different. Okay, our second layer of draping is the top or the table drape. And again, it should be fluid, impervious, and it also allows the surgeon to step up to the table and lean against the table without contamination. One of the most important concepts about your top drape is that it needs to completely cover the table and the patient, no matter what size that is. So when you pick up a top drape, they also are purchased and they're also always folded the same way. There's two ends that are accordion pleated. The top drape, no matter where you're doing surgery, is always placed in the center of the patient and then unfolded so it completely covers both ends of the table. So here we see, I picked up the drape and you see the two ends, accordion folded, I'm finding the center. I'm holding it in place and unaccording the rostral end and dropping it. My hand doesn't go below the table. Switch hands and unfold the other end. So it's completely covering the table. I'm holding it in place and unfolding it towards myself. It's great to have an assistant or a nurse to come in and grab the drape under the table and help you unfold it. I can reach a lot across because I have very long arms, but other people might have to walk around. Now that I have the drape there, I can lean against the table. I never want to reach my hand below the table like that. If you can't unfold it, somebody else non-sterile needs to step in and get below the table where the drape hasn't completely folded. Once the top drape is on, the light handles can be placed. Okay, you don't want to place your light handles before you place the drape. Somebody will come and slide the instrument table up once the drape is on. So once you're up next to the table, you now are starting to create that surgical field. Okay, again, as you can see in these slides, a non-sterile assistant can grab the very ends of your drape because they're going to be below the level of the table. And you'll be surprised in surgery, somebody comes right up to help you. Again, on the right, we want to make sure the entire table is covered. So it does make it a little challenging for the anesthesiologist, but we don't want the dogs or the horse or whatever you're working on, their head out. Okay, so what do we do now that we have to have this top drape on? We want to make sure that we expose our surgery site. So I gently palpate and feel for my towel clamps, and I'm going to cut an eye like the letter I. So I usually go straight up the middle of the incision and cut, and then I'm going to make little cuts on either end because what I want to do is be able to just fold that top drape away, and we're going to clip it to the bottom drape. Why do we do this? Okay, so you see I have those cuts, and now I'm going to fold the edge under and just take a clamp that I'm not going to be using in surgery, and I'm going to take a small bite and clip that top drape to one of the four corner drapes in the corner. The reason for we do this is because when surgeons stand up next to the table and they're leaning and they get nervous, they start swaying back and forth. And if you don't clip the drapes together, the top drape is going to keep sliding and it'll be out of your surgical field, and then it's going to create havoc. So you always want to make sure the drapes are hooked together so that when people are leaning against the table, your drapes don't move. So again, any type of clamp, I just picked four that I'm not using, and now our surgical site is exposed and our drapes aren't going to move, and the surgeon can step right up to the plate there. This is what it looks like over top. You'll notice that when you go to put the four clamps on, you just want to grab the very edge of each of the drapes. If you take big bites and then lay the clamp handles back, it'll cause your drapes to roll up and pull away from the skin. So just small bites and then lay the handles out of your surgical field. Okay. Now we just have a quick overview. Surgeons up to the table, instrument tables up, and we have a drape on the floor by which we can throw sponges so that they can be counted and assessed after surgery. So our whole surgical field is together. So there it is, kind of in a quick summary. And you know, it looks easy. I think everybody, when you first start doing it, you really have to think about it, and we're there to remind you. Inevitably, somebody's going to be at the surgical table and they're going to feel like their glasses are slipping and they're going to reach up and push their glasses, or they're going to immediately have to scratch their nose or their ear. You'll find that, you know, all these things happen and you don't even realize what you do. But hopefully in the process of the practice surgeries we do on cadavers, that will continue to work with you, and it'll become very natural to you by the time we're done. I hope this has been informative. I know it's a lot of material, but we're going to put this into action in the lab, and hopefully it makes a lot more sense to you then. Thank you for your time.